Dear viewers, this is part 2 of the two-part series on blood groups transfusion in the Medicine for Anyone in the YouTube channel. Blood typing. Before giving a transfusion to a person, it is necessary to determine the blood type of the recipient and donor blood so that the bloods can be appropriately matched. This process is called blood typing and blood matching, and these procedures are performed in the following way. The RBCs are first separated from the plasma and diluted with saline solution. One portion is then mixed with anti-A agglutinin and another portion is mixed with anti-B agglutinin. After several minutes, the mixtures are observed under a microscope. If the RBCs have become clumped, that is agglutinated, then an antibody-antigen reaction has resulted. The blood type and their reactions to the anti-A and anti-B sera are shown below. Red blood cell type O, sera anti-A, no agglutination, anti-B, no agglutination. Red cell type A, sera anti-A, agglutination, anti-B, no agglutination. Type B blood, anti-A sera, no agglutination, anti-B, agglutination. Red blood cell type AB, anti-A sera, agglutination present, anti-B, agglutination present. Type O RBCs have no agglutinogens and therefore do not react with the anti-A or anti-B agglutinins. Type A blood has A agglutinogens and therefore agglutinates with anti-A agglutinins. Type B blood has B agglutinogens and agglutinates with anti-B agglutinins. Type AB blood has both A and B agglutinogens and agglutinates with both types of agglutinins. Dear listeners, by the way, this educational video is made possible by Prescribon, the makers of e-prescription software for digital prescriptions, available freely for doctors on the website www.prescribon.com. Doctors who are interested in this e-prescription can freely avail of its vast collection of more than 100,000 e-prescriptions. RH blood types. Along with the OAB blood type system, the RH type system is also important when transfusing blood. The major difference between OAB system and RH system is the following. In the OAB system, the plasma agglutinins responsible for causing transfusion reactions develop spontaneously, whereas in the RH system, spontaneous agglutinins almost never occur. Instead, the person must first be massively exposed to an RH antigen, such as by transfusion of blood containing the RH antigen, before enough agglutinins to cause a significant transfusion reaction will develop. RH antigens, RH positive and RH negative. There are 6 common types of RH antigens, each of which is called an RH factor. These types are designated capital CDE and small letter CDE. A person who has a capital C antigen does not have the small c antigen, but the person missing the capital C antigen always has the small c antigen. The same is true for the D and E and D antigens. Also, because of the manner of inheritance of these factors, each person has one of each of the 3 pairs of antigens. The type D antigen is widely prevalent in the population and is considerably more antigenic than the other RH antigens. Anyone who has this type of antigen is said to be RH positive, whereas a person who does not have type D, capital D antigen is said to be RH negative. However, it must be noted that even in RH negative people, some of the other RH antigens can still cause transfusion reactions, although the reactions are usually much milder. About 85% of all whites are RH positive and 15% are RH negative. In American blacks, the percentage of RH positives is about 95%, whereas in African blacks it is nearly 100%. Over 95% of Native Americans and Asians living in China, Japan, and Korea are also Rh positive. And it is estimated that the worldwide frequencies of Rh positive and Rh negative blood types are 95% and 6% respectively. Rh immune response. Formation of anti-Rh agglutinins. When RBCs containing Rh factor are injected into a person whose blood does not contain the Rh factor, that is, into an Rh negative person, anti-Rh agglutinins develop slowly, reaching a maximum concentration of agglutinins about 2 to 4 months later. This immune response occurs to a much greater extent in some people than in others. With multiple exposures to the Rh factor, an Rh negative person eventually becomes strongly sensitized to Rh factor. Characteristics of Rh transfusion reactions. If an Rh negative person has never been exposed to Rh positive blood, transfusion of Rh positive blood into that person will likely cause no immediate reaction. However, anti-Rh antibodies can develop in sufficient quantities during the next 2 to 4 weeks to cause agglutination of the transfused cells that are still circulating in the blood. These cells are then hemolyzed by the tissue macrophage system. Thus, a delayed transfusion reaction occurs, although it is usually mild. On subsequent transfusion of Rh positive blood into the same person, who is now already immunized against the Rh factor, the transfusion reaction is greatly enhanced and can be immediate and as severe as a transfusion reaction caused by mismatched type A or B blood. Erythroblastosis fetalis, otherwise known as hemolytic disease of the newborn. Erythroblastosis fetalis is a disease of the fetus and newborn child characterized by agglutination and phagocytosis of the fetus RBCs. In most cases of erythroblastosis fetalis, the mother is Rh negative and the father is Rh positive. The baby has inherited the Rh positive antigen from the father, and the mother develops anti-Rh agglutinins from exposure to the fetus Rh antigen. In turn, the mother's agglutinins diffuse through the placenta into the fetus and cause RBC agglutination. Incidence of erythroblastosis fetalis. An Rh negative mother having her first Rh positive child usually does not develop sufficient anti-Rh agglutinins to cause any harm. However, about 3% of second Rh positive babies exhibit some signs of erythroblastosis fetalis. About 10% of third babies exhibit the disease, and the incidence rises progressively with subsequent pregnancies. Effect of mother's antibodies on the fetus. After anti-Rh antibodies have formed in the mother, they diffuse slowly through the placental membrane into the fetus blood. The agglutinated, they cause agglutination of the fetus blood. The agglutinated RBCs subsequently hemolyze, releasing hemoglobin into the blood. The fetus macrophages then convert the hemoglobin into bilirubin, which causes the baby's skin to become yellow, that is jaundiced. The antibodies can also attack and damage other cells of the body. Clinical picture of erythroblastosis. The jaundiced erythroblastotic newborn baby is usually anemic at birth, and the anti-Rh agglutinins from the mother usually circulate in the infant's blood for another 1 to 2 months after birth, destroying more and more RBCs. The hematopoietic tissues of the infant attempt to replace the hemolyzed RBCs. The liver and spleen become greatly enlarged and produce RBCs in the same manner that they normally do during the middle of gestation. Because of the rapid production of RBCs, many early forms of RBCs, including many nucleated blastic forms, are passed from the baby's bone marrow into the circulatory system and it is because of the presence of these nucleated blastic RBCs that the disease is called erythroblastosis fetalis. Although the severe anemia of erythroblastosis fetalis is usually the cause of death, many children who barely survive the anemia exhibit permanent mental impairment or damage to motor areas of the brain because of precipitation of bilirubin in the neuronal cells, causing the destruction of many of these cells, a condition called kernicterus. Treatment of neonates with erythroblastosis fetalis. One treatment for erythroblastosis fetalis is to replace the neonate's blood with Rh negative blood. The Rh negative blood is infused over a period of 1.5 or more hours while the neonate's own Rh positive blood is being removed. This procedure may be repeated several times during the first few weeks of life, mainly to keep the bilirubin level low and thereby prevent kernicterus. By the time these transfused Rh negative cells are replaced with the infant's own Rh positive cells, a process that requires 6 weeks or more, the anti-Rh agglutinins that had come from the mother will have been destroyed. Prevention of erythroblastosis fetalis. The D antigen of the Rh blood group system is the primary culprit in causing immunization of an Rh negative mother to an Rh positive fetus. In the 1970s, a dramatic reduction in the incidence of erythroblastosis fetalis was achieved with the development of Rh immunoglobulin globin, an anti-D antibody that is administered to the expectant mother starting at 28 to 30 weeks of gestation. The anti-D antibody is also administered to Rh negative women who deliver Rh positive babies to prevent sensitization of the mothers to the D antigen. This step greatly reduces the risk of developing large amounts of D antibodies during the second pregnancy. The mechanism whereby Rh immunoglobulin globin prevents sensitization of the D antigen is not completely understood, but one effect of the anti-D antibody is to inhibit antigen-induced B lymphocyte antibody production in the expectant mother. The administered anti-D antibody also attaches to the D antigen sites on Rh positive fetal RBCs that may cross the placenta and enter the circulation of the expectant mother, thereby interfering with the immune response to the D antigen. Transfusion reactions resulting from mismatched blood types. If donor blood of one blood type is transfused into a recipient who has another blood type, a transfusion reaction is likely to occur in which the RBCs of the donor blood are agglutinated. It is rare that the transfused blood causes agglutination of the recipient cells for the following reason. The plasma portion of the donor blood immediately becomes diluted by all the plasma of the recipient, thereby decreasing the titer of the infused agglutinins to a level usually too low to cause agglutination. However, the small amount of infused blood does not significantly dilute the agglutinins in the recipient's plasma. Therefore, the recipient's agglutinins can still agglutinate the mismatched donor cells. As explained earlier, all transfusion reactions eventually cause immediate hemolysis resulting from hemolysins or later hemolysis resulting from phagocytosis of agglutinated cells. Hemoglobin released from the RBCs is then converted by the phagocytes into bilirubin and later excreted in the bile by the liver. The concentration of bilirubin in the body fluids often rises high enough to cause jaundice. That is, the person's internal tissues and skin become colored with yellow bile pigment. However, if liver function is normal, the bile pigment will be excreted into the intestine by way of the liver. So, jaundice usually does not appear in an adult unless more than 400 milliliters of blood are hemolyzed in less than a day. Acute kidney failure after transfusion reactions. One of the most lethal effects of transfusion reactions is kidney failure, which can begin within a few minutes to a few hours and continue until the person dies of acute renal failure. The kidney shutdown seems to have three causes. 1. The antigen antibody reaction of the transfusion reaction releases toxic substances from the hemolyzing blood that cause powerful renal vasoconstriction. 2. Loss of circulating RBCs in the recipient, along with production of toxic substances from the hemolyzed cells, and the immune reaction often causes circulatory shock. The arterial blood pressure falls very low, and renal blood flow and urine output decrease. If the total amount of free hemoglobin released into the circulating blood is greater than the quantity that can bind with haptoglobin, a plasma protein that binds small amounts of hemoglobin, much of the excess leaks through the glomerular membranes into the kidney tubules. If this amount is still slight, it can be reabsorbed through the tubular epithelium into the blood and will cause no harm. If large, then only a small percentage is reabsorbed. Yet, water continues to be reabsorbed, causing the tubular hemoglobin concentration to rise high enough so that the hemoglobin precipitates and blocks many of the kidney tubules. Thus, renal vasoconstriction, circulatory shock, and renal tubular blockage together cause acute renal shutdown. If the shutdown is complete and fails to resolve, the patient dies within 7 to 12 days unless treated with an artificial kidney. So, dear viewers, this is the end of part 2 of the two-part series on blood groups transfusion in the Medicine for Anyone in the YouTube channel. Thank you for watching.